To introduce the speaker of the first talk this morning, New Methods of Delivering Iron to Dialysis Patients. This is going to be given by Dr. Stephen Fishbane, who is Chief of Nephrology at Northwell School of Medicine, Great Neck, New York. Steve, it's a pleasure to welcome you. And Dr. Fishbane will also give another very fascinating talk on hypoxia-inducible factors in this session later on. Thank you.
Thank you. Great. Thank you for being here. Thank you for being here. Appreciate folks getting up so early for this. We're going to be speaking today about new approaches to treatment for iron and anemia management. So I'll start off with a question for you. This is not one of those poll everywhere ones. It's more just to kind of get you thinking a little bit. And the question is, things have changed a lot over the past 5 years. So as you think about anemia treatment, which of these do you think has been true? Have hemoglobin levels in American dialysis units been increasing? Have there been higher doses of ESA treatment? Are there lower intravenous iron doses being used or increased serum ferritin? And I'll let you think that through. Try to at least formulate what you think is the answer. And we'll go forward and look at some of the data that helps us understand this. And this is important, right? This is something that we need to understand a little bit better. I can use my laser pointer on both sides, so I'm going to favor this side. I'm trying to mentally count how many people are on each side, so we'll probably go on this side. Well, the laser's not really working, but this usually works. But not in all cases. So what you're looking at right now are hemoglobin levels since 2010. And notice here the really important change that took place with the advent of bundling in the United States. Because what you're seeing here is the lower three categories, but especially that middle tan category increasing, so that the higher hemoglobins that were previously present, look back at the far left, and you're looking at people with hemoglobin levels that were getting up to 12 to 13 or higher, decreasing substantially. The blue area not really changing, I think, very much, which is 11 to 12. But where you're seeing a lot of change is the 10 to 11 area that has increased sharply, and even the bottom two areas, which are people with lower hemoglobins, increasing. So you'll be happy to note that people with hemoglobins of less than 9, that really bottom light blue color, has not increased very substantially. There we go a little bit. And this section, which is people with hemoglobins below 10, which I still don't think is good for patients. You know, there are some that would disagree with me on that, has increased to some extent. So one change that has occurred is that hemoglobin levels are generally lower than they had been previously. No judgment, is that a good or a bad thing? It's just a change that has taken place. The amount of EPO to get there. Now, this is really interesting how EPO doses have changed in the United States. So people with hemoglobin doses of greater than 50,000 units over the course of a week, that was not inconsequential. It's about 10% of patients back in 2010, and it really doesn't exist much anymore. But people, in the range of 10 to 50,000 units has decreased substantially. And I think the biggest change that you see is in the light blue area. So folks with EPO doses less than 5,000 units. There's been a really big increase, probably a doubling, right, from about 20 to 40% of patients who are treated. So EPO dosing has decreased, and decreased dramatically over the past 5 years, which is a second really important secular trend which has occurred in American dialysis facilities. Intravenous iron, two stories here. The first is the more important one, which is from 2010 right up till about 2012, there was an increase. So 50% of patients had received iron in the past month, and that increased to about 70%. And that remains true today. So about 70% of patients are getting intravenous iron on a monthly basis. And that's, a fairly high number, and we'll talk about why that may or may not be a concern. By facility setting, for some reason there's less in hospital settings than there are in freestanding settings, and don't jump to quick conclusions here, because I'm not sure that there is a very straightforward answer to why this one is the case, but it's one that I find interesting. In terms of the drugs that are used, as you might be familiar with, iron sucrose evolved and emerged as by far the victor in terms of the market for intravenous iron. And while there are several different intravenous irons that are truly available right now, you really see very little use in the United States of anything other than iron sucrose. And, look, it's a fine drug, so that seems like a fair place to get to. By the size of the organization, I don't see any real trends here that I think are important, so I'm not sure that it matters how large the dialysis organization is to explain some of these trends. But this is one that I'd like to frame a little bit more. So let's understand this. Now, your Ferritin value right now is probably the lowest in the room is in the 30s to 40s, which is getting to be a little bit iron deficient, and maybe the highest in the room right now is 100, 150, but you're not going to find in this room much more than that. And yet American dialysis patients, and you'll remember, what is serum ferritin? Well, it's kind of a pretty good approximation of what iron storage in the body is. And there's other things that throw this off, but it's how much iron has been locked away in the storage tissues in the liver, the bone marrow, and spleen. And this is a relevant number for us to try to understand for our patients' well-being. And that did increase, and it increased from 2010, 2011. I've got the laser on the left-hand side, from the 550 range up to about 750. I've been tracking this pretty closely, and it's got as high as 832. Average ferritin in the United States, 832. We're not higher than 100, 150. 832. The average now is about 750 in the United States. And that's a question that needs to be answered, which is it okay to be leaving people with such high serum ferritin values? There's been, surprisingly not a tremendous amount of interest in trying to understand that better. Now, if you look at how things have changed with a longer-term perspective, so let's go back to when intravenous iron really became popular. And if you look back to 1993, you see that the average ferritin in the United States was about 300 for dialysis patients. It increased, so by the mid-1990s it had risen to about 500. it plateaued at about 600 and then burst upwards in the part that I didn't show you in the last slide, which was this increase, which got us up to the 750, 800 range, from the 300s to the 500s to the 800s. Now, that is a profound change for a population of patients, regardless of disease, a lot of magnitude in terms of change there. And at the same time, we're going to be real careful with this. So this is hospitalizations of American dialysis patients. Now, if you look at USRDS, you're not going to see this. You have to tease this out in kind of a special way. It's a hospitalization in which one of the coded problems was that there was bacteremia present as well. And you see that as intravenous iron use and ferritin values rose, there was a parallel increase in hospitalizations for bacteremia. And when that level plateaued for a few years with a little lag, that number plateaued again. And I don't know what has happened with the more recent surge. So that does not mean that increased iron use, increased ferritin values caused the increase of bacteremia that it was seen. It's an association between two factors, which may not be cause and effect. It may be related to other things in our population, more catheters, older population, different types of dialysis starts, but it's something that we would want to know the answer to, wouldn't we, in terms of the increased use of iron and increased infections? So, you know, it's an area of interest, and we're doing some research in this area right now. And that kind of parallels this, which has been that we've done really well in terms of the care of dialysis patients in the United States, arguably over the past 20 years. The overall rate of hospitalizations and death have decreased. The number of time spent in the hospital has decreased. You won't be surprised to know that vascular excess hospitalizations have dropped dramatically. That's good, that's good. So a lot less hospitalizations there. But the one thing that has gone up has been infections. And it does, again, at least raise the question of what are we doing in dialysis patients that might be causing the increase in infections. So I'm going to be not so subtly putting out there the proposition for you today that we don't, in 2016 on September 10th, really understand well enough what is the relationship between intravenous iron and potential risk for infection. It's a really big interest for us and for a couple of other groups around the world right now that are trying to study this subject. And it's worthy of study, because nobody, right? I mean, if there's somebody that wants to raise their hand and says that they don't want to understand better why infections are going up, why hospitalizations for infections is going up, you know, feel free to defend it, but we need to understand it better. That's, you know, I think the point. So, look, I mean, hemoglobin levels have been declining. ESA doses are declining. Intravenous iron use increased but stabilized. Serum ferritin increased but stabilizing. So that it's a really different world in 2016 than it was just 5 or 6 years ago. And there's a lot of economics, I know, that plays into all of this. But there's also a lot that we've learned about anemia treatment and safety in treatment as well that's potentially important. So on the iron area, which is the main reason that we are gathered together this morning, let's talk about iron and where we stand right now. So intravenous iron, since I started in the area, has gotten to be easier to use, I think less expensive, but look, I mean, the rate of anaphylaxis, it used to be, and there's not a lot of people here who were treating patients in the mid-1990s, but, I remember very well an experience I had probably about 1995 or so, where the nurse was going up to a patient and she had a syringe filled with this black liquid, and before injecting it, she kindly remarked to him, if you feel like you're losing consciousness or you're not going to be able to breathe after I inject this, just let me know. Goes forward and injects the medication. And I spoke to her a little bit about why that might not be a good idea to do. There is this thing of aversive conditioning where people don't react well when you prepare them in what way. But the drugs do seem to be better now to readily available supply. We haven't seen shortages, and gosh, I mean, vascular access here is really easy. You've got the drug, you've got access to the circulation 3 times a week. So intravenous iron, I think, has been a really big success. The most important part of it is if you think back again to the 1993 period when ferritin values were so low, when 50% of patients on dialysis had transferrin saturations of less than 20, 1/4 of patients on dialysis were just starved of iron. This was a really important advance at the time. Iron is not just anemia. Iron is important for a whole bunch of reasons in terms of our overall health. So it was a very important advance. But, we will raise a question about whether we've gone a little bit too far here. Because on casual inspection, when you inject iron into a patient, they generally look okay. The patient seems to be doing well, and we walk away and we inject the next patient with iron as we get our 750 ferritin values in the United States. But there's issues that are important to think about. And what I'd like you to consider is the difference from normal biology. So here's what you are going to do over the next 24 hours, and you started with breakfast today. You're going to consume something like 10 milligrams of iron from the diet, 10 milligrams. You're going to do it over 24 hours, and slowly from your intestines, that 10 milligrams of iron will be absorbed into your bloodstream. And you've got these incredible regulatory mechanisms to protect against too much of that iron from getting into the bloodstream. The body wants what it needs and will work hard to protect that. And you'll end up getting about 1 or 2 milligrams if you're a menstruating woman, maybe 5 to 10 milligrams, or if you've had a bad bleeding episode. But you're going to end up slowly, gently absorbing a couple of milligrams of iron over the next 24 hours. When you inject intravenous iron, you're going to take not 10, not 5, you're going to take 100 milligrams of iron. You're going to inject it not over 24 hours, but you're going to do it over 5 minutes, directly into the bloodstream, not going through the intestines, and that is tremendously different than the normal biology of iron. And sometimes it's completely fine to be different than normal biology, and certainly a lot of medicine is based on being different than normal biology. But it does raise questions, because the Europeans in particular, for the past 10, 15 years, have shown us that if you just take 100 milligrams of iron sucrose and inject it into the bloodstream, the patient may look okay, but at least 50% of dialysis patients and at least 50% of normal volunteers, just that 100 milligrams of iron sucrose, are going to get oversaturation of transferrin. So transferrin in the bloodstream sops up the iron, carries it to where it needs to go, but there's not enough of it. When you inject so much into the bloodstream quickly, you get just what is a lot of free iron that's present in the circulation. And that free iron has been indisputably demonstrated to cause a burst of oxidative stress. And as a result of that, If you take that blood with the free iron, Drs. Parkkinen in Finland showed that bacteria like Staph epidermidis, a pretty important bacteria to us, grows rampantly in the blood when that much iron is present. There's a burst of oxidative stress. Drs. Horrell and the late Dr. Horrell and his colleagues showed that your blood vessels don't dilate for 6 hours afterwards, and have compared it to smoking a pack of cigarettes. So, look, when we're injecting our 100 milligrams of iron sucrose, people always love to criticize this data by saying, well, it's laboratory data, it's animal. It's not. It's human studies that have shown that you're giving them something which is potentially detrimental to health. That being said, we don't know for sure that it does any harm. Maybe getting that little burst of oxidative stress, which you definitely get, maybe that's not harmful. Maybe it's long-term oxidative stress that's harmful to people. Maybe the short-term effects in terms of being able to fight off bacteria don't really matter. So we need good outcome studies to understand the subject much better than we currently do. But for anybody who thinks that there's not reason to have concern, and gosh, it would be tremendously incurious, if there's such a word as incurious of us as a community, after we've gone through the whole ESA problems of the past 10 years, to just say, well, okay, we learned about ESAs, but our huge rampant use of intravenous iron, well, that's okay. No, we need to understand this subject better. So our problem in the bottom bullet is that we just have very limited clinical data available to understand what this actually means in terms of health outcomes of interest for these patients and safety for these patients. We've had studies with small numbers of patients, short follow-up, inadequate safety assessment. So just recently, the typical kinds of studies that get done, which are really good studies to understand the efficacy of these drugs and the short-term effects of giving the drugs, but they tell us nothing about the long-term effects of repeated treatment. But this was a very nice study from a couple of years ago with Ferric carboxymaltose, very nice drug, 163 hemodialysis patient, great demonstration of efficacy. The authors concluded that Ferric carboxymaltose was well tolerated, but we've got like 50 of these kinds of studies in the literature, and they contribute very little to any understanding about injecting 100 milligrams of iron directly into the bloodstream over 5 minutes and what that means in terms of real safety. But increasingly, we're seeing the epidemiology and studies of such getting us more concerned about what we're doing. More recently, Rajiv Agarwal, who I think is speaking later today, published a study which was NIH-sponsored, which was stopped early by the sponsors. It was in CKD, not dialysis, but they compared IV to oral iron, and it was stopped because of increased cardiovascular events in the intravenous iron group, increased infections in the intravenous iron group. The study has been criticized, so we never want to take one study and make big generalizations based on it, but additional reason to want to try, I think, to learn more about this subject. A really good study taking place right now, maybe with results later next year. Ian McDougall, the greatest world's expert in anemia and iron, has what's called the pivotal trial, which is a very large long-term study of intravenous iron treatment to higher and lower targets. I think one of the most important studies being done in the hemodialysis world in terms of safety. But right now, we don't know enough. We need to know more. And I'd like to suggest to you that there are reasons to have concerns about intravenous iron safety. So that opens up interest in trying to learn about newer treatments. And I think there's really two that are new treatments that are out there and available at the current time. The first one is an oral drug, which is ferric citrate. And I'm going to mention one time for each the brand name in the United States, just for people that don't know generic names. So I'm not trying to be commercial here. I just want to try to give some connection on them. So this is called Auryxia, and Julie Lewis and Vanderbilt published in February of 2015, so not that long ago, just a year and a half. Nice RCT, 440 patients that were part of it, and they were randomized to ferric citrate or an active control. So let me just set this straight, immediately, because you need to understand this. So active control, ferric citrate, iron, ferric, it's not a study of iron, it's a study of phosphate binders. Ferric citrate is a phosphate binder. The ferric part of it binds phosphate and is going to prove, as we'll see, to be a really effective phosphate binder. But some of that iron gets into the body as well, and that's why it comes up in this talk as being a pretty important drug. So the active controls were things like sevelamer and calcium acetate. And what Julie showed was that she was able to get increases in ferritin values with ferric citrate compared to active control. If we look out to 48 weeks, for example, the active controls are about, 500. The ferric citrate's about 800. So the drug, although it's a really effective phosphate binder, it works as well as other phosphate binders, it also happens to deliver iron. Transferrin saturation shows you what is about the same. So interesting drug. I don't think we've had a lot of drugs like this in nephrology. I can think of a couple that span different domains, so mineral and bone disease, anemia, and with efficacy in both areas. Now, there was some concern here because 9% of the patients on ferric citrate had at least one measurement of ferritin greater than 1,500. Now, that was true in the active control also, but I'll show you a little bit more about that. Interestingly, in the last 6 to 9 months, so if I have successfully created at least some concern in your mind that we need to understand more about intravenous iron safety, well, I think it is a helpful finding that about 40% of the patients were able to come off intravenous iron during the active control period. So, I'm sorry, only 40% still required any intravenous iron during that period. So they did achieve something in terms of reducing the overall need for intravenous iron treatment. Her group published, Umanoth was the lead author, a more detailed look at the anemia aspects. The first paper was more focused on phosphate binding, and it was a good phosphate binding drug. So this was a detailed analysis of some of the anemia outcomes. So it looks like kind of the same slide, but there's one big difference here, which is that she now shows all of the outlier results, and this is kind of important. So what she shows you is that with ferric citrate, you do get a lot of patients. Just look right over here at 48 weeks. With active controls, I'm not sure that I see anybody who's much over 1,000, and yet you see patients going up to the 2,000 ferritin, 3,000 ferritin level with ferric citrate. And it's a little bit hard to understand. It's an oral iron drug, and people have written articles about how oral iron, including me, doesn't work in people on dialysis. Well, there you go. It does work, and here's the first drug that has actually shown the ability to make that happen. So they wanted to understand why, giving this phosphate binder that also has oral iron in it, why they were getting these big increases. And they had what was termed an adjudication group to try to understand these increases in ferritin. So in the ferric citrate group, 57 people had ferritins of over 1,500. They generally resolved, so that's good. Stop the drug, the levels come down. The drug was caused, though, by IV iron administration in 23 of the patients. So although it was off protocol, you weren't supposed to give iron, I think, IV iron if the ferritin level was over 1,000. It looks like there was some study conduct issues. So, that remains to be seen a little bit better. The FDA didn't look at it that way. The FDA put in pretty stern warnings into the label about avoiding very high ferritin values with the drug. Umanoff continued to show that intravenous iron use was substantially decreased. And in fact, if you looked at the dose of intravenous iron people were getting, it was down to 12.9 milligrams versus 26 milligrams per week. It's more than a 50% reduction. So, kind of like that. I think that's certainly a move in the right direction. Their Japanese partners, Yokoyama and L, who's a really good investigator from Japan, showed the same things. The higher the dose you use, the higher the ferritin values you tend to achieve. You get a really nice effect in terms of hemoglobin levels compared to controls. And intravenous iron use, they showed practically disappeared completely with the use of ferric citrate. So you've got a drug that allows you to bind phosphate and is as effective as the sevelameres and the calcium acetates apparently, and which also essentially treats iron. So it's an interesting drug that is one, that can certainly be thought about. In the non-dialysis population, I'll just mention quickly because we've done a couple of studies on this. So we published this in May of last year. This was a phase 2 study, 149 patients not on dialysis yet, 12 weeks, double-blinded ferric citrate versus placebo. And we showed, sure, transferrin saturation goes up with ferric citrate, hemoglobin goes up with ferric citrate, ferritin values go up as well. And I guess what I didn't show there was something that really interested us was that FGF23 levels, which doesn't usually move much with a phosphate binder, were decreased by about 43%. And at ASN this year, we'll be presenting the results of our phase 3 trial, which I've chosen not to show results of here. So it works in the non-CKD population. But this is going to be interesting because in hemodialysis, the drug is indicated. It's out there. It's commercially available as a phosphate binder that delivers iron. In the non-dialysis population, this is a drug that is going to seek FDA indication as an iron supplement. And it'll lower phosphate a little bit also, but if you haven't really seen this kind of move. They did a cost-effectiveness analysis, and they found that the drug did seem to be important in terms of overall savings that were achieved. So it is a drug that is interesting as an effective phosphate binder. It allows for significant lowering of intravenous iron exposure, and I think it's important until we understand more about IV iron safety that we do have ways of exploring these possibilities. Depends on how you use it, but you could get significantly lower ESA dose requirements and potentially lower cost of care as well. So, my opinion is if you're using this drug, if the patient has a ferritin of 200 to 800 and needs a phosphate binder, I think IV iron should be stopped. You should start at a recommended dose, although 1 pill 3 times a day is probably fine. Titrate as needed, but do it to maintain phosphate control, not as an iron treatment. And then if iron levels happen to go low, just give intravenous iron as necessary. So let's switch over to ferric pyrophosphate citrate, and the brand name here is Tryfarik. And this is a drug in which the iron is delivered not orally now, but through the dialysate during the hemodialysis treatment. So let me say that again, that with the dialysate, just like you've got all these other substances in the dialysate that are infusing into the circulation, you've got iron that is moving into the circulation as well. So this is based on the concept that dialysis patients lose about 5 to 7 milligrams of iron with every dialysis treatment. And again, this is where our concerns always end up coming in. You give somebody 100 milligrams of iron sucrose once a week, you're giving 5 grams of iron per year, and it's very hard to believe that patients could stay in a net neutral balance. So in contrast, by giving this drug, you are matching the patient's losses. As they lose 5 to 7 milligrams of iron, you're hoping to just gradually seep in about the same 5 to 7 milligrams of iron per treatment. Not what you're doing with intravenous iron, of this huge bolus of iron getting into the circulation, but rather just trying to gently match the iron losses that are taking place with the dialysis treatment. And the patients lose iron with every dialysis because of our needle sticks, blood that gets trapped in the lines. And this iron loss is one of the primary reasons for anemia in these patients. So the concept here is, with the relentless loss of iron that takes place, that you simply, instead of trying to bolus with huge doses given directly into the bloodstream, seep iron in a more gradual and gentle way to match the losses that are taking place during the treatment. So FPC then, as you look at the blood and dialysate compartment, as things like urea and other nitrogenous toxins are moving out of the blood and into the dialysate, just like calcium is moving into the blood, FPC with iron is also moving into the blood. And it delivers just about 5 to 7 milligrams of iron with every dialysis treatment. So what you're losing is essentially what you're getting back. It's an iron salt, so it moves very easily through the dialysis membrane. The iron is very tightly bound to pyrophosphate, and to me this is important. This is just a quirky little thing if you happen to be interested in iron. Some of the newer iron drugs leak iron pretty easily into the circulation. This is tightly bound to pyrophosphate, so it's carried cleanly through the circulation, which kind of was the first thing that attracted me to this drug about 6-7 years ago. And then once entering the blood, it's immediately taken up, the FPC, to transferrin and carried to tissues with transferrin receptors, most notably the bone marrow, where red cells and red cell precursors are going to be produced, not potentially locked away in storage tissues where the drug may not be usable. So that's a helpful property of the drug. Some of the things that have been seen which are helpful with it is that you don't get increases in hepcidin and you don't get inflammatory responses to injection, which has been helpful. You don't see blockage of the iron in the spleen, in the liver, and elsewhere, which we've seen a lot of with studies by Guido Stocker in Paris and others who've used MRIs to look at dialysis patients. You will never get anaphylactoid reactions with this drug. It's small, it is taken up immediately, and it's infused so slowly that it's never been seen in more than 100,000 doses, and I don't think it ever could be seen with the drug. So it's an interesting difference in the way the iron is delivered. So compared to intravenous iron, again, instead of these huge boluses over short periods of time, we like the fact that it's a small amount of iron that is going in much slower and more gradually. I can't tell you right now that you get less oxidative stress, less iron available for infection. but I can't think of any way possible that by administering iron this slowly that you could possibly get those same effects that you get with intravenous iron. No anaphylaxis. IV iron, you don't see much anaphylaxis anymore, but there are the rare reactions that we all do see. Now, in terms of the amount of iron that you're giving, so continuous treatment over 7 weeks with FPC is basically equal to what you get with a single dose of intravenous iron. And it's the big difference. It's quantitative. It's giving it slowly over the course of the dialysis treatment. So at the end of last year, we published a paper on the phase 3 study. These were the Cruise 1 and Cruise 2 studies. These were phase 3 studies in 599 dialysis patients who apparently had enough iron. So this was maintenance, like you give intravenous iron once a week to maintain iron stores. The goal here was to try to maintain iron balance in these patients. Patients were dialyzed either with a standard dialysate with placebo or 2 mics of FPC iron. You could not give intravenous iron. So during the randomized phase of this study, there was not a reduction, there was no intravenous iron given to either study group. And in addition, you couldn't change the ESA dose either. So that was interesting. You just had to freeze the ESA dose, keep it that way over time. There were some quirky reasons that it had to be done this way, but it created some really elucidating information in terms of anemia treatment. And the primary efficacy endpoint was change in hemoglobin concentration. This is how patients kind of moved through the course of this study. And the one point that I would like to make here is it was a study with several phases. So the key randomization phase, which is how the evaluation of the drug took place, there was a lot of people that left that phase and went forward into phase 3, which was not an evaluation phase specifically because of anemia mandated reasons. So this was a time when the FDA had tremendous vigilance, although it's really not different today, in terms of anemia treatment and what you were doing. And it created some really tough constraints, but it still gave us a really nice window to be able to evaluate this drug and how the drug worked. So when we looked at hemoglobin, we found that, not surprisingly, FPC gave you hemoglobin levels that essentially remained stable over 45 weeks, whereas with placebo, you see that that hemoglobin levels eventually start to break down and decrease over time. The iron parameters show you that with FPC, if you look at transferrin saturation, if you look at CHR, which is a really nice measurement of iron status, you get better effects in terms of iron with FPC through the dialysate than you do in the control group, which is not getting iron, which is not getting any intravenous iron at all. And in terms of ferritin, you see a little bit of a drift downwards with the FPC group versus a gradual and larger drop with the active control group. So the drug is efficacious, and it was certainly enough to convince the Food and Drug Administration that the drug deserved FDA approval. I want to make a different point, though, here, that with FPC, so now if you give intravenous iron on a regular basis, what you will see is if you give about 50 milligrams a week of iron sucrose to a population, the ferritin values will remain about stable. If you give 100 milligrams, the levels will tend to increase, and if you give it more than that, I mean, there's really not a reason to give more than that. But with this drug, my opinion is that because you have all different types of people in a dialysis facility, that you're going to see some patients that stay the same, but you're going to see a fair number of patients that are going to need intravenous iron treatment from time to time. Remember, no intravenous iron at all was given in this study, but I think you'll see people that have bleeding or other issues that do require treatment with intravenous iron. Now, what happens during the dialysis treatment? So when you give it through the dialysate, does the iron actually get in and do something? And, you know, here's what happens. Let's just look at serum iron concentration. So FPC black, placebo grayish, and you see that pre-dialysis, they're about the same. Post-dialysis, the level goes up very sharply in the FPC group as compared to the placebo group. So indeed, the iron is getting into the blood. That's what drives that stabilization of ferritin and transferrin saturation over time. So giving iron through the dialysate does work to get iron into the circulation. Safety. So what was seen here was the treatment emergent adverse events were about the same between placebo and FPC. Drug-related events were close between the two, just a little bit higher in the FPC group. There were 16 deaths, 10 in the FPC group, 6 in placebo. None were considered related to study group. And I'll say the totality of the evidence of this drug over the courses of study is that there's simply nothing at all that has evolved in terms of a safety issue. But I'm going to give you the same caution that I gave for intravenous iron, although I believe that this makes sense as a more sensible way to match normal biology. Instead of injecting 100 milligrams over 5 minutes into the circulation, let the iron drip in slowly. It's still not a long-term safety study that really helps us understand what we need to in terms of patient outcomes for safety. So I think it's probably a safer way to give iron. That still needs to be proved better. In terms of hypotension, so IV iron definitely causes some hypotension, usually not horrible. You don't see iron hypotension with FPC except what is baseline levels that you see in the population. There was one non-serious case of suspected hypersensitivity. It looked like it was really due to hypovolemia. Again, I don't believe that hyposensitivity is really possible with this drug. There's no carbohydrate that's part of it. It's basically 3 natural compounds that are found in the body that quickly dissociate and associate with transferrin. So, it remains to be seen with further study. Gupta and a group did a little bit of a different study in which they wanted to understand the effects on EPO dosing. And so this is an interesting study. It's called the PRIME study. This was published in KI in November. It's a 9-month randomized placebo-controlled study, 103 patients undergoing hemo. The FPC group, again, 2 mics per liter of iron compared to the placebo group that got standard dialysate. This is a consort table simply showing how the patients were allocated over time. There's nothing really here for me to explain on this slide as in the previous slide. But what they found here, again, was interesting. First showing what happens with the dialysis treatment and just replicating what we showed before, that indeed you do get an increase with the dialysis treatment in the amount of iron that gets into the circulation, and that will increase your transferrin saturation, and serum iron will increase and will increase over the course of time in patients who are treated with FPC. But that's looking at pre and post dialysis treatments. What you find in terms of real changes over time is that the ESA dose that's required, once you get out past week 28, you get a substantial difference in that the placebo group has a gradually increasing need for ESA. And that's logical because as you gradually break down your iron stores and develop some iron deficient erythropoiesis, you're going to develop a need for more ESA to be able to maintain the hemoglobin level. And what you see is essentially, it looks like it goes a little up and down, but I would just call it stable FPC requirements. So you end up with about a 20-30% reduction in ESA dose requirements with FPC compared to placebo treated over the course of time. When you look at intravenous iron usage, again, you see that you decrease intravenous iron compared to placebo, and pretty substantially. Serum ferritin values between the two groups better maintained, but this didn't quite reach statistical significance, but it's close enough that it's almost certainly a real change that took place. So the authors concluded that a 35% reduction in prescribed ESA dose was achieved compared to placebo. Patients used 51% less intravenous iron than placebo, and similar adverse event profiles between placebo and the FPC treatment. So when you put together the whole safety database, looking at people who've, over 1,000 people that have gotten the treatment for up to 18 months, it's 100,000 doses. There's been no increase in intradialytic hypotension compared to placebo, no increase in infections, iron toxicity or overload, no increase or oxidative stress or inflammation as it's been looked at, and the overall adverse event profile is similar to placebo. And for the FDA panel that heard about this drug, they were, I think, really moved by those points in particular. So the safety profile looks good. It looks like what I would expect when you're not injecting a lot of iron directly into the circulation. But again, I'm always going to have the caveat that for any iron that we're injecting, we want to understand over the course of time what safety might look like. Looks good, though. Economics, so this has been looked at. This is not my strong suit, but I'll try to make some sense of this. So if you're giving this drug and get the EPO reduction, you're going to get savings over the course of time per patient. You're going to be using less disposable and have nursing savings that go along with that. So you have potential cost savings that were estimated in this analysis of between $680 to $2,000 per year with the use of, sorry for the use of the brand name, but for FPC versus current treatment. So how do you actually do this as I complete my talk? The drug is given by the dialysates. You've got two ways of doing it, and one is that you give it through central distribution, and in the bicarbonate portion of the dialysate, you add FPC to the liquid bicarbonate. Different ways in different states. For us, it would be a nurse giving it. I don't know in different states how you would do this. You're adding it to the bicarbonate, and if you want to do it this way, you can. So our units have 200 patients in each unit. You would simply be giving it as part of the dialysate to all 200 patients in the unit. And because you're giving such low quantities, all you're doing is essentially matching the needs of those patients. And then over the course of time, you're still doing iron testing, and as needed, you're either increasing or decreasing the amount of intravenous iron that's required, which should generally be fairly low in the groups that are being treated. You could also just give it to individual patients. So you have your jug of dialysate. It would be a drug added to the jug of dialysate. Remember, you of course always have to label for whatever drug that you're adding to the drug, but FPC 5 mLs, it's an ampule. You add it to a 2.5 gallon jug that's used at the dialysis machine. So you could do it for an individual patient. You could do it for an entire dialysis facility. Why would you do it for an entire dialysis facility? Because every single patient on hemodialysis loses iron with every single treatment. So it's a pretty sensible approach, I think. And I have a protocol, and this didn't scan well. I should have had a better graphic. I apologize to you. But my thought on this, and there's others that may differ with me, is that if you're doing it through the dialysate for all patients, you would check iron every 3 months. If the patient has a ferritin level of greater than 1,000 or a T-set of greater than 50, I would decrease FPC and any IV iron that's being used, the IV iron first. If you don't have excessively high iron levels, which you very rarely should ever have with this treatment, then I would simply check to see if the ferritin is less than 200. And this will happen where you're going to get some patients, especially patients that maybe have some occult bleeding, that will still need treatment. And I would then give them a course of intravenous iron before returning to just normal FPC dialysate treatment. And otherwise, if everything is in range, we just keep testing every 3 months. So in conclusion, these are two new routes of iron delivery. They both have a lot of promise. They're different. One of them is an oral drug that's a phosphate binder that is able to deliver a good amount of iron into the circulation. The other is given through the dialysate and in a way that kind of more gently mimics the normal biology of how we absorb iron. They both have a lot of promise, I think. And on the broader note, as you inject your iron and write prescriptions for iron for your patients and watch the patient get the drug, please just don't casually assume that what we're doing is necessarily safe for patients. There's good reasons to believe that we need to understand better what we're doing with widespread IV iron treatment. So we'll be looking really closely for the McDougall pivotal trial. But in general, I think a fair statement is until you have visibility and until you have the full knowledge that allows you to balance risks and benefits of treatment, you should always err a little bit more on the conservative side. So thank you for your attention. Real happy to answer any questions that you might have.